Leukemias, as we all know, are the blood cancers which have evolved from the clonal proliferation of the myeloid hemopoietic tissues, and they are aggressive malignancies. At times, they are so undifferentiated that we are, by using the modest equipment, we are unable to define the lineage. Why lineage is important for the diagnostic standard for leukemia is that lineage would define the treatment. By and large, for myeloid and lymphoid malignancies, the protocols are different and the outcomes are also very different. Now, a few years back, we had the classification of leukemia based on the clinical findings. What the patient present in days and weeks would be taken as acute leukemias, whereas those who have presented in months or years would be labeled as chronic ones. And we had got very primitive, I would say, the gadgets of microscopy, which would define the myeloid, the lymphoid, based on just the morphology. As the years go by, we started having cytochemical staining, and which would define the specific granules or the presence of any special stain to define these last further. And I remember the days once the patient would start working in our institute from the oncology, and the oncologist would call us, they just tell us whether it's myeloid or lymphoid so that we can write the chemotherapy protocol. So that is the basic diagnostic approach at that time, clinical plus microscopy. But now, along the exponential increase in the diagnostic modalities, we have now known that genetics, genomics, and molecular characteristics of the leukemias are important for defining the treatment. So today, once we talk about the gold standard for the diagnosis of leukemia, we talk about the genetic lesions. And as we know that these are mostly, in case of three-fourths of the leukemias, these are acquired somatic mutations combined with the epigenetic changes, which is not actually the change in the sequence of the DNA, but the factors which would affect the presence of a mutation of a genetic or malignant clone. So this, with this understanding of leukemia, three-fourths of the leukemias would have a series of genetic mutation, while still we have a group of inherited disorders like Down, like Lee-Forman syndrome, like other Fanconi's, in which there are germ cells mutation. Talking about the genetic lesions in leukemias, mostly three-fourths of them are acquired somatic mutation, whereas 1/3 of the leukemias, they come up with the germline inherited mutations of the malignant clone. Whatever would be the lesion, it would ultimately affect the cell cycles, different phases. Either it would interrupt the transcription, or it would be acting at the splicing level. Then epigenome, as I have told you, that it is the expression of the written mutation on the gene which would not be expressed. Then there are certain molecules which would be added toward this, which would give rise to the secondary changes. Like we now know that there are first-line genetic lesions, which in case of myeloid leukemias, which are more aggressive in phenotype and clinically, we would have TET, ASLX mutations, which are lying there already, in which they would be added up by the second-line mutations like FLT, RAS, RUNX1, and would result in the malignant aggressive clone. Now, for today, the standard of care includes the stratification of these leukemias on the basis of SEPA, NPM1, and the FLT3 definitions after we diagnose it as myeloid malignancy. Now, today we know that we do not only need to diagnose the leukemia, we need to define it as it is related to the myelodysplastic syndrome, because the management plan which we make after the lineage definition of a leukemic patient would differ for a de novo myeloid malignancy as compared to that which has evolved from a therapy-related leukemia or from myelodysplastic. Again, we need to have strict criteria to define impending relapses of the leukemias. What would be the diagnostic criteria? Right after the definition of the lineage and the origin, we need to know the stratification of the leukemia. Then at the time of diagnosis, we should be able to diagnose the oncological emergency which are related to the leukemias like DIC and tumor lysis syndrome. But more importantly, we need to know how to maintain the leukemics in remission status and how to proceed with the continuous treatment. So all these modalities must be answered in the diagnostic algorithm for leukemia. Now, 2 decades back, somehow we had this joy of knowing that we have cured leukemia by inventing the targeted therapies or by reverting the genetic lesion. And the Novartis company came up with the targeted solution. So we can kill leukemia just like we can kill plasmodium with anti-malarial drugs. But this joy was short-lived. Shortly after that, we came to know this was not 1-to-1, 1+1 equation, but it's much more than that. So more of the Philadelphia chromosome positive patients would not have CML. They rather would be giving a bad prognostic marker for an ALL, or we would have CML-like phenotypic picture and the presentation, while the juvenile CML was without any Philadelphia chromosome. And then we came to know that there were isomers which were having different outcomes of 210 or 190 molecular weight of the fusion protein. So with that, we came to know that not only knowing the genetic lesion, we need to know that it evolves continuously. It evolves with the same Philadelphia chromosome as etiological factor. It goes to the acceleration phase and then it goes to the blastic phase. Similarly, there are other hematological cancers which show that with 15-17 translocation, the result would be APL, but there's another translocation like 11-17, or the prognosis and the clinical course for that APML would be quite different from the regular one. So this is with regard to an individual person suspected with hematological malignancy, but what about the international language of the disease? Classification, we know that is the language which internationally is followed by the pathologist and oncologist, because once you treat or diagnose leukemia in Pakistan and after treatment, we just had a patient presented with the favorable acute lymphoblastic leukemia. We started with chemo induction. The child went to the remission, first CR remission, and now the family is moving abroad just to get the transplant done in UK. Now they are asking for the genetic markers for the ALL, which is not available, of course, with the whole panel which the oncologist sitting in UK is demanding. So whatever we diagnose or treat or plan is related to an international level interpretation. Today we know that we are going to follow the 2022 classification, which is WHO 5th edition, which is in congruence with the international consensus classification for myeloid neoplasm and acute leukemia. And now it incorporates morphology, clinical attributes, the cytopenias or cytosis, lineage, and cytogenetic and molecular features, both of the classification. And so in order to diagnose, we don't only need to know the lineage, we need to know the class of the leukemic clone, the entity, typical entity and subtype. For example, if we know that is mature B-cell malignancy, then whether it's large cell or aggressive type, or it's a mature B cell, is it diffuse large B cell lymphoma, lymphoblastic leukemia, or it is going to be which type of immunoblastic or other type, germinal zone and diffuse large B cell lymphoma. So we need to know the precise diagnosis, and we do have that diagnostic tools available, but first thing is not only the availability, the accessibility of these diagnostic modalities is very, very important. The standardization of these protocols, the price we have to pay for this diagnostic workup or algorithm. So WHO 5th edition has defined essential and desirable diagnostic criteria. The essential ones are the minimal criteria to allow the diagnosis and which is universally acceptable, whereas desirable are those modalities which are in confirmation or for the refinement of the diagnosis. And we all know that considering the financial aspect of our oncology community, most of the time we have to give them food beside that the chemotherapy, which should be free. So what we talk about the flow cytometry or usual private setup would be offering would be asking for more than 40,000 just for the flow cytometry. So though we have specific modalities standardized available in the market, but the accessibility of the leukemic community to those modalities is again important. So we need to, in order to make an algorithm which is practical for all leukemic patients, we need to start from the bone marrow biopsy with special stain, with flow cytometry, with fission cytogenetics, and for more type of malignancies, PCR. NGS or the next generation sequencing, I had made a big question mark over there, because maybe this is out of the research labs, but still in the clinical labs, this is quite, I would say, not practical. Though I'm standing on the seminar for the NGS, but I still say that though there is a beginning for NGS, but the affordability and the standardization of the protocols would hinder it for quite a near future. Now, I would discuss with you a few modalities which are important and have been added to the routine algorithm for leukemia diagnosis. One of them is cytogenetics, and at times you know that the cytogenetic report is the final for example, PML, RARA, or CML diagnosis. Plus that we would have stratification, or the not only diagnosis, the second step of the prognosis of the patient is only based on certain favorable, intermediate, and adverse groups of cytogenetic lesions. If we have got complex cytogenetics, or we have got certain monosomies, or with that genetic MLL gene rearrangements. So the protocol for initiation of the leukemia treatment right away changes. But the thing is that those cytogenetics are available. It takes quite a long time for the patient to have those prognostic marker or diagnostic. As compared to that, FISH is a rapid and more accurate diagnostic modality, which in the right hands would be a big aid for the diagnosis. Then comes the flow cytometry. As I've told you, that's quite expensive, but in certain type of leukemia, we need to have the flow cytometry with the proper panels, and which would define. Without that, the correct diagnosis of leukemia would not be possible. Early T-cell precursor acute lymphoblastic leukemia is one such example, because this is a type of TLL in which we would have a poor outcome of the patient, and the patient would have relapses, induction failures, and that is only defined by the leukemic clone, which would have very early precursor markers with the CD7 positivity, whereas CD1A and 8 would be negative to this malignant clone. Now, this would differ from, for a discussion for a TLL, which is much less commoner as compared to the BLL in our community. First of all, the diagnosis itself is correct. Diagnosis is difficult. Plus, the subtypes like ETP with the MPOL and T myeloid with acute undifferentiated leukemia would not be possible unless you have a correct flow cytometric panel as well as the interpretation. Then there is another type of ETP in which we do not have that grave outcome of the patient, which is near EPT ALL, in which CD5, beside all those markers which we have just narrated, would be positive for the malignant clone. It would be showing myeloid precursor markers, but it should be MPO negative. So all this is only possible by this flow cytometry. Plus, we should know that almost 20% of the myeloid acute leukemias, they do present with some co-expression of the lymphoid marker like CD7, 19, and 2. Whereas true mixed phenotypic acute leukemias are rarer, and they also need quite an extensive panel. Now, it seems like flow is the last and the confirmatory test for a diagnosis of the right patient, but all those things which can be counted at times do not count. So if the sample for the flow is not appropriate, this is one recent example in Shifa that MRD was taken from a very diluted bone marrow sample, but luckily we did have a refined biopsy, and you can see that the flow is showing the MRD positivity of around 2%. 2% BALL cell positivity, whereas the IHC is showing the positivity of TDT markers about 70 to 80% in refined biopsy. So a diluted sample can mislead for MRD evaluation by flow. So it's very important. The person behind the wheel is said that is important. The pre-analytic samples, or if you are not comparing the other modality, otherwise we would take IHC as much less sensitive instrument for diagnosing or marking the prognosis of a patient. Then comes the genetic. As I told you that these are the genetic lesions which come in a series of mutations. They should be diagnosed by the modalities which can detect variation in the genes. If we know the lesion, then we can amplify that lesion by PCR, by cytogenetics and molecular cytogenetics in form of FISH. We can record it. The gene expression profiling is not that common in clinical labs, but for a standard prognosis and management plan, we need to have the gene expression profiling at the time of diagnosis, once the patient went into remission, and then once the patient, it was again relapse. So we need to have that profiling and compare it, what happens to that. Then conventional sequencing is next generation sequencing is again in the market, but we do not have standard myeloid gene panels. The future of the diagnosis from the gene would be the point of care devices. And by using artificial intelligence, we should be able to read this out. So my time is up. So I would quickly tell you that a few years back, once we went for our training for cytogenetics and FISH, we were taken to a big room, and it was shown that this is Sanger sequencing going on. And it was obviously not possible to have that gene expression profiling of the whole genome by the Sanger, which would obviously take longer times, 60 years, they say. But now with the NGS, we would have a more speedy, high throughput technology. but we need to define whether it would tell us about the probabilities of the inherited leukemias or malignancies, whether it can be used for population screening. The use of NGS in diagnostic labs is, I think, is a far future, because that would need a lot of data collected for at national level, and then there is some role on the disease monitoring. So what would be the best choice for a genetic testing? Then what would be the clinical significance of the data which we get from the NGS, and whether we should be ethical and moral issues are that whether we should be sharing with the patient or with the patient family with regard to propensity of the future malignancies. Now we know that it is not 1+1. We know that the lesions, if we revert the fusion proteins, it would not end up the leukemia. So we need to find out more targets. And for there are other aspects of the disease. For example, the pharmacogenomics shows that the same tumor, same leukemias with the same chemotherapy protocol, one would go to the complete remission, whereas other leukemia would not show any, would be totally resistant. And the studies have shown that it's more than 1,000-fold of the drug dose that would differ in the patient blood. Now, the future would be as the diagnostic approach to the leukemia is related to the leukemogenesis. Why do we want to understand the leukemia? Because we want to make a tablet which can undo it. We need targeted therapy. So in future, mannan inhibitors are coming up in the markets, which would act as a wedge between the gene. Rather than reverting the fusion protein, we are actually reverting the gene which is affecting the leukemogenesis. So for that, we need to go from more toxic chemotherapy to the immune therapies, and we need to define the targeted revisions of the genetic lesions. I thank you all for the patient listening. I would acknowledge the participation of my flow department and the residents who shared the cases with me. The story of the diagnosis of acute leukemia is very sad. It was sad 30 years back. It is still sad, especially for myeloid leukemias. At times, we are able to diagnose it correctly on time, but what's the fun of diagnosing a patient and not letting him to the treatment available? So I would say it's the money which matters in the hand of oncologists, whether we want to spend it all in the diagnosis or we want to treat it with that money. Thank you very much.
Assalamu alaikum. So my target audience is basically our friends who are not physicians. So it's not, it's about awareness. It's not exactly a 100% scientific talk. Dr. Aisha, they were detail mein discuss kiye in. So basically the month of September worldwide is celebrated as the awareness for hematological malignancies, which one is leukemia, lymphoma, and myeloma. So this is our hospital, the beautiful Islamabad, and this slide is important. जो leukemia, lymphoma, और myeloma में हमारा जो सफर शुरू हुआ आज से 40 years, everything was in the mist. We were not clear. So it started with a gunshot therapy, which is chemotherapy. It doesn't has any targets. It kills rapidly replicating cells. So last 30 to 40 years, the mist has started clearing. And we as hematologist community, we stand for the hope. We have a dream that some of our dreams may not be fulfilled in our life, but this is how we stand for. If we would not, as we know that leukemia, lymphoma, as myeloma, they're all life-threatening illnesses. But it's tough. It's tough for the hematologists, for the society, but we are hopeful that one day we would head for cure. So basically, I'll have just a brief talk about, it's about symptoms, diagnosis, and treatment for for my friends who are not physicians. So first thing is awareness. Why should we talk about awareness? about blood cancer, lymphoma, and myeloma. So it's a spectrum. As we do recognize, a lot of it revolves around very costly investigations, but subset of it is still curable. Like example is chronic myeloid leukemia, which we discussed. So this I have already discussed. I'll skip that. Symptoms, इलामात क्या होती हैं? Normally, so lymphoma and leukemia is a spectrum. Most commonly, I would say कि बगैर किसी वजह के वजन कम हो रहा है. You have fever which doesn't go away. The lymph nodes start appearing. So basically, why should we know about these symptoms? Because these are the symptoms: fatigue and waist loss, thakawat, weight loss, fever, infection, night sweats, lymph nodes enlargement, bruising, bone pain. All of these patients, ये सारे मरीज पहले जनरल पब्लिक में जीपी के पास जाएंगे. So for general public as well as for our general physicians, it's very important to recognize where to draw a line. आपने line कहाँ पे draw करनी है और exact referral कैसे करना है? Because this is a common story. We see fever, weight loss, or enlarged lymph node. The first diagnosis is TB, or most of our patients वो TB की दवाई 3 से 4 महीने ले चुके होते हैं by the time they end up with us. Some of them have complications because of this. So diagnosis, डॉक्टर आयशा ने डिस्कस किया है आपसे कि डायग्नोसिस कैसे करें. उसमें मैं सिर्फ 2 या 3 पॉइंट्स हाईलाइट करूंगा कि of course meticulous physical examinations is important, which all of our physicians, our internists do, the blood tests and the imaging studies and the biopsy. So detailed medical history of physical examination क्यों important है? Because it rings up certain bells in your mind for an experienced physician that there is something wrong. Why somebody is requiring transfusion, they started bleeding or having fever, and then refers it to an appropriate person. Blood test में सबसे most important blood test क्या जो बिल्कुल inexpensive है, and that is blood complete picture with the peripheral smear, जिसको आप सादा आम माइक्रोस्कोप से देखते हैं, which is, and but this one test, अब इसकी सबसे बड़ा मसला क्या है कि you got to have a trained hematopathologist look at it. So there is no great software अभी तक इजाद, I don't know कि ऐसा कोई इजाद हुआ है. जो भी है that is very sophisticated. See, the flow cytometry और जो sophisticated test है वो बाद में आते हैं, सबसे पहले blood. So my message is that if you have any abnormal cells appearing, please refer to a center who have expertise in this. There are a bunch of physicians, the hematopathologists who have special expertise, who have decades of experience at looking at it. So you go in a stepwise pattern, because all investigations are costly, महंगी हैं तो कि आप पहले blood test देखते हैं, उसमें abnormal cells, the platelets are down, the hemoglobin is down, and biopsy. So most important is one, if you suspect, अगर आप suspicion है कि patient has lymphoma, so lymphoma के लिए important है कि अगर आराम से हो सकती है, signal the whole lymph node should come out. Not possible, then true cut. So true cut is a special biopsy technique जो कि either it can be done in a lymph node जो कि सामने नजर आ रहा है, और by guiding image guided CT or ultrasound guided. So the unfortunate चीज ये कि for patients जिनकी lymphadenopathy और जो ultrasound और CT scan पर नजर आ रही है, patients have unnecessary surgeries for lymphoma, which causes a lot of morbidity, जो बिल्कुल नहीं होनी चाहिए. Like we come across patients के lymphoma के लिए Whipple's procedure, pancreas और आंतें सारी निकल गई हैं, which has a lot of morbidity, तो नहीं होनी चाहिए. So it's about awareness कि आप एक सादा biopsy से तशखीस कर सकते हैं. And of course, Dr. Aisha ने बहुत डिटेल में डिस्कस किया है कि what a bone marrow biopsy is. So my message is, see, bone marrow, getting only a bone marrow biopsy is not a great technique. It can be mastered, but interpretation, उसके लिए you got to have a team of very good hematopathologists with a backup proper. You got to have immunohistochemistry special test और flow cytometry. अगर आपके पास ये टेस्ट मौजूद नहीं है, it's better कि जिस पेशेंट को आप सस्पेक्ट कर रहे हैं कि उसकी बोन मैरो बायोप्सी करनी है, उसको रेफर टू ए टर्शरी केयर सेंटर, which are just few, I can count them on fingers. I think पूरे पाकिस्तान में डबल डिजिट्स में नहीं है वो सेंटर्स, if I'm not wrong. तो what we come across is कि patient ने एक bone marrow biopsy करवाई है 3 दिन पहले and you end up with absolutely no diagnosis, or what we call is a dustbin diagnosis. There is no diagnosis and you request another bone marrow biopsy. That is a bit unfortunate. So there should be some public understanding or some measures taken by the government that bone marrow biopsy procedure should be done only in centers which have proper backup. They go in an algorithmic pattern. मगर वो पहले bone marrow biopsy करते हैं, उसके बाद you run a Dr. Aisha flow cytometry. It's expensive test. You require a great expertise in this. You got to have immunohistochemistry or cytogenetics. अगर आपके पास ये नहीं है, आप सिर्फ bone marrow biopsy कर रहे हैं, तो I think it's just because patient will get another procedure in a couple of days time. Treatment I'll not discuss, but it's just one thing that blood cancer or lymphoma or even myeloma is not a death sentence, as the general perception is. खून का cancer या lymphoma is a death sentence. There is no real cure at all. Some of it is expensive, but some of it is not. Like lymphoma की कुछ treatment है, जैसे Hodgkin's lymphoma एक lymphoma की type है. It is not. You got to have an appropriate diagnosis first. And we have survivors of decades, which I'll mention one type of leukemia. Leukemia की अकसाम है, acute leukemia, chronic leukemia. जैसे एक किस्म है chronic myeloid leukemia. Story starts from almost 2000, and we have patients now living for more than 2 decades now. So blood cancer is not synonymous with the blood is with death. Some of it is curable with certain modalities of treatment. I'll not go into details, but one misconception which everybody asks, how painful or drastic is giving chemotherapy? Chemotherapy kitna zyada pechida hai. It's a great art. Giving chemotherapy is both science as well as art. But chemo administration in skilled hands is not a painful procedure, which is a public perception. It's extremely painful. No, it should not be painful. It has serious life-threatening side effects which can be taken care of. But proper chemo administration is not painful. Next, we have radiation part of it, जो हम lymphoma में use करते हैं, हम bone marrow transplant के लिए radiation use करते हैं conditioning, and stem cell transplant is ये यानी एक तरह से आप मौजूदाती इलाज कह सकते हैं कि of hematological malignancies के blood cancers के लिए जो high risk blood cancer है जिसका आप transplant करते हैं, somebody you expect will not live for 3 to 4 months, been living for decades with bone marrow with stem cell transplant, which basically means कि आपने disease marrow की जगह healthy marrow दी है. I'll not go into details of immunotherapy. We do use immunotherapy, especially for lymphoma patients, जिसका मतलब है कि आप अपनी ही जिस्म की मुदाफियत को बढ़ाते हैं ताकि वो बेहतर काम कर सके, has less side effects. Targeted therapies have started for the last, now we say, one of the first breakthrough थी chronic myeloid leukemia में जब Gleevec imatinib आई थी, but we now continue to build new therapies which inshallah will be very, very helpful in the future. Prevention, of course, all of us know, okay, lifestyle changes, toxins, regular checkups. Awareness का impact क्या है कि basically community should come up with a support, especially in our resource limited settings, where treating hematological malignancy, blood cancer related is very, very difficult because this is not state sponsored. So community needs to know that whatever they are contributing may be life-saving. It's not just throwing away your money for nothing. So this is the basic purpose of awareness. You can go for fundraising, help the community or build up a community of the patients जो कि आप एक दूसरे को psychological support कर सकें. जैसे chronic myeloid leukemia patients का Western world में is the blogs in which you share a common man's experience कि आप or it's very, very educating, very, very educating. And I think all of you know this gentleman. This is Kareem Abdul Jabbar, one of the most famous basketball players in the history. Still alive. He was diagnosed 2008 with chronic myeloid leukemia and still doing very well. So he's not on chemotherapy, of course, he's on tablets. Okay, he's been on one of the tablets, nilotinib. So I just wanted to show this because these are encouraging stories. If people have lived for years, this is chronic myeloid leukemia, but acute leukemia ke saath bhi with appropriate treatment, people can live, but they need your support, in fact. Thank you so much.
Bismillah ar-Rahman Rahim. Thank you very much, the organizers, for inviting me in this forum. So I would like to continue the message of hope which Dr. Azhar Shafi actually gave. The greatest poet of subcontinent and the Sufi poet, Dr. Allama Muhammad Iqbal said, "Jahan taza ki afkar taza se hai namood, ke sango khisht se hote nahi jahan paida, wahi zamane ki gardish pe ghalib hota hai, jo har nafs se kare umre javedan paida." So I think once we look at hematological malignancies, the most of the hematological malignancies seem to follow the path. And the exponential revolution which we have seen in acute myeloid leukemia over the last few years is a testament to that. I do not have any conflicts of interest. Over the last 3 years, there are 3 major updates which we have seen in acute myeloid leukemia. One of them is MRD guidelines, which were actually put forward by European Leukemia Network. So it was first time in the history of acute myeloid leukemia that measurable residual disease was established as an entity for the purpose of prognostication and therapeutics. Another major shift in acute myeloid leukemia was the new guidelines which were proposed by ICC and WHO, and we'll see how actually they changed the landscape of acute myeloid leukemia treatment. And then on the basis of these classifications, European Leukemia Network and later NCCN actually changed their recommendations for management. If you look at 2022 WHO classification of hematolymphoid tumors, we know that the AML classification is now divided into 2 different families. One of them is AML with defining genetic abnormalities, and another one is AML defined by differentiation. The main reason for splitting AML into these 2 different categories is extremely different paths that a physician will take once AML is diagnosed and treatment and prognostic decisions are taken. On the basis of this WHO 2022 classification, ELN was first to react. ELN was first to react to change their classification of AML, on the basis of which we act as physicians, hematologists, oncologists, manage our patients. So if you look at this classification, those highlighted in red are the changes which were made. So the favorable risk classification actually added BZIP in-frame mutation in CBPA. Another breakthrough which we say was that in intermediate classification, FLT3 ITD was added. We know that historically, FLT3 was considered to be an adverse risk cytogenetics. But because of the availability of targeted agents that are FLT3 inhibitors, it was seen that FLT3 inhibition resulted in improvement in outcomes, and FLT3 mutated AML is no longer an adverse risk cytogenetic abnormality and is considered as an intermediate one. In adverse risk cytogenetic abnormalities, there were few mutation abnormalities which were added, which include RUNX1, ASXL1, SF3B1, TET2, EZH2, and on the basis of these mutations, actually these highlighted in red are behind the bar, which we are seeing. So there were few mutations which were adverse risk and they were added on the basis of genetic stratification. So once WHO classification was changed in 2022, the risk stratification was changed. The next step was how to incorporate these changes in initial workup. So ELN now recommends that for all patients who are worked up initially for risk stratification, there are a few mandatory investigations which needs to be conducted. Screening for genetic mutations, those highlighted in red are FLT3, IDH1, and IDH2. And why they are mandatory? Because these are actionable mutations. we have targeted agents against all these agents, all these mutations. So once these mutations are targeted, we have an improvement in outcomes. Another one is NPM1. NPM1 was categorized as a separate entity because we know that NPM1 is one of the strongest predictor if tested by MRD, which can actually affect the outcomes. NPM1 MRD was the first MRD which was established in AML. And then there is plethora of genetic testing, which is actually seen. So if you see, there are two types of mutation analysis, which is visible in these slides. One of them is those who will be done on NGS, like FLT3, IDH1, IDH2, NPM1, and other are gene rearrangements, which can be done by PCR-based technologies. So once we are looking at the diagnosis of AML, now it is important to have initial genetic workup right. And we know why it is, because now once we classify acute myeloid leukemia, there is a step-by-step algorithm which is established by ELN that first of all, you have to check for recurrent genetic abnormalities, then TP53 mutations, then mutations by NGS, then mutations by cytogenetics. And if you find anything out of them, you label the patient accordingly. And if you do not have any of them, then you label the patient as AML, not otherwise specified. So with this background of what evolution has done over last few years in AML, in diagnosis and risk stratification, now we'll see why it is important to have a patient risk stratify at outset. If you look at 1970 till 2010, so these 4 decades do not see any single new agent in management of acute myeloid leukemia. Gemtuzumab was initially introduced in 2000, but was later withdrawn because of severe side effects. But if we look at 2017 onwards, 2017 is considered as a breakthrough year in acute myeloid leukemia history because it was the first time that targeted agents were approved, which actually resulted in changing outcomes of acute myeloid leukemia. Then come 2018, we have 4 new drugs, 2019, another drug, 20, another drug, 22, another 3 drugs, and another 4 drugs in 2023 in acute myeloid leukemia. So a disease which had no drug, new drug approved for 4 decades, has now more than 16 drugs in last 5 years. So I'll just follow up with few of the cases from our institute, which actually highlights why it is important to have genetic testing and incorporation of genomics. A 32-year-old male presented with leukocytosis and bicytopenia. Bone marrow examination and flow cytometry was consistent with acute myeloid leukemia. PCR for NPM1 and FLT3 mutation was positive, and NGS panel documented DNMT3A mutation. So we know that although this patient had FLT3 mutation, but as far as revised classification is done, this patient is now classified as intermediate risk AML rather than adverse risk AML. So what is the upfront treatment we'll advise and how we'll assess MRD in this case? So conventionally, we would have treated this patient with 7+3 regimen, but this is how we treat acute myeloid leukemia newly diagnosed in 2023. So we look at whether we have got a core binding factor mutation, which is a favorable. And in these cases, we can add gemtuzumab ozogomycin, which is a targeted agent anti-CD33. If we have a FLT3 mutation, just like in this case, we'll have a FLT3 inhibitor like midostaurin, quizartinib, gliteratinib, sorafenib. If there are no targetable mutation, we'll just give induction chemotherapy. If it is therapy-related AML, we have another targeted agent, that is CPX351. And if we do not have any targeted agents, our patient is TP53 mutated, we can consider novel combination, which is HMA-venetoclax. So our patient received D3S7 with midostaurin. We know midostaurin is a FLT3 inhibitor. So patient received D3A7 plus midostaurin induction and HiDAC plus midostaurin consolidation as a bridge. Post-consolidation, MRD was positive for NPM1 by real-time PCR. So this case highlights 2 important things. One, we add a specific targeted agent, that was midostaurin. And secondly, when we assessed the MRD, it was positive for NPM1 mutation. And we know that if we have, sorry, there is again, this is a bar which is hindering. So I'll just like highlight, if we just see the statistics below that black bar. So in intermediate risk AML, if MRD is positive, there is 70 to 80% chances of relapse of this disease. So this patient has 70 to 80% probability of relapse. So this patient underwent match-related donor allogenic transplant with minor ablative conditioning, and we gave this patient sorafenib, which is a non-specific tyrosine kinase inhibitor post-transplant maintenance. Post-transplant, patient was in CR, MRD was, NPM came out to be negative, but once we repeated NGS, it was again positive for DNMT3A mutation. We know that DTA mutations, that is DNMT3A, TET2, and A6L1 post-transplant, do not correlate with relapse or survival outcomes. If you look at summary of this case, FLT3 mutation is no longer incorporated in ELN risk stratification as an adverse risk cytogenetic abnormality. Now it is an intermediate risk. MRD for NPM1 is useful for therapy decisions and relapse monitoring. So NPM1 is the single most MRD marker, which is very, very important. DTM mutation should not be considered as an evidence of MRD, and MAC is preferred in AML patients, especially if MRD is positive. Post-transplant FLT3 maintenance improves outcomes. So these are the FLT3 inhibitors which are approved. So out of FLT3 inhibitors, these are the drugs which are targeted agents which are used. These include midostaurin, quizartinib, gilteritinib, and sorafenib. We are frequently using sorafenib at our center, midostaurin in our patients as upfront therapy. Sorafenib is a cheap medication. We know 1 month cost is around 10 to 15,000 per month. And sorafenib is the only drug in FLT3 mutated AML which has shown to improve outcomes in this phase 2 trial, which was Forman trial, and another phase 3 trial which was conducted in China. Our second case is case of Professor Mehreen, who is sitting here. So he's a 32-year-old patient who presented with easy bruising off and on for 2 years, and complete blood count showed hemoglobin of 11.5, WBC of 4.1, and platelets of 10. Bone marrow examination showed dysplasia in all cell lineages with 14% blasts. Cytogenetics showed monosomy 7. So this is a classical case which we see of acute myeloid leukemia with monosomy 7, poor cytogenetic abnormalities. But once we sent NGS, it came out to be ankyrin D positive for ankyrin D26 mutation. And we know that ankyrin D26 mutation is associated with myeloid neoplasm with germline predisposition. That means this is an inherited acute leukemia. And if you have got an inherited acute leukemia, it has its implications in further treatment. So this was the panel which was sent abroad, and it actually showed ankyrin D26 mutation. A very important finding is that although ankyrin D26 mutation is pathogenic mutation, it was labeled as a variant of undetermined significance. It is because the library which the Western data has got does not have representation of mutations which are in our center. So in our area, in our region. So recently we had reported a case of dyskeratosis congenita, which was published in Blood. We have reported 3-4 variants of von Willebrand disease, which were labeled as VUS, but they are pathogenic. And we are reporting them, and they are being added to the library. So importance of identifying germline predisposition in this case is that this patient cannot undergo transplant or further treatment from a donor unless that donor is being tested and is negative for germline predisposition. Because if the donor also has this mutation, then the transplant would be a disaster. And this is the classification, ICC classification. So now there is a separate entity, hematological malignancies with germline predisposition, and we know that ankyrin D26 mutation is one of them. Our next case is a 38-year-old male who presented with leukocytosis, thrombocytopenia, and right-sided abdominal pain. Peripheral film had 90% blast. Flow cytometry was consistent with AML. Cytogenetics and AML gene panel for fusion gene abnormalities, NPM1 and FLT3-ITD was negative. So what is the risk stage of this patient? As per this history and AML gene panel, the patient is intermediate risk AML. But once we sent the genetic testing panel, the patient came out to be RUNX1 positive, U2AF1 positive, and TET2 positive. And if we see the VAF values, the VAF value of RUNX1 in this case was more than 40%. So that means this can be inherited, this can be somatic, but in both cases, it is a poor risk AML, not an intermediate risk AML. Because if you see, RUNX1 is one of the adverse risk cytogenetic abnormality. Again, it is behind the bar, highlighted in red. But RUNX1 is one of the poorest cytogenetic abnormality. So the next challenge was whether it is germline predisposition or this is somatic. So what we did was we took a buccal swab of the patient and we sent it abroad for testing. Because if it would have been a somatic mutation, germline buccal swab should be negative. So in this patient, the patient had a negative buccal swab for RUNX1, but a positive buccal swab, positive blood test for RUNX1 mutation with a VAF value of 40%. Another evidence that this patient was not germline was that once we treated the patient and we give induction regimen, we repeated the NGS. And once we did NGS, RUNX1 and U2FN mutation was negative. So that means it was a somatic mutation, which was no more in post-treatment sample. And this patient then went on to receive allogeneic stem cell transplant in CR1, which he might not have received because we would have labeled him as intermediate risk AML. And currently the patient is in CR. And RUNX1 is also will be used as one of the MRD marker. The last case is a 79-year-old male who presented with lethargy, easy fatigability, and pallor. CBC showed pancytopenia. Bone marrow examination was consistent with AML with maturation. Cytogenetics were normal. Genetic testing documented NPM1 mutation and EZH2 mutation. Patient had ECOG1 and was ineligible for transplant. If we reverse the time and we go back 3 to 4 years and we see a 79-year-old patient who is diagnosed with AML, we'll just put this patient on supportive care and say, thank you very much. You had enough in this life. But with the advent of new drugs, the scenario has changed drastically. So this is a chart which shows that patients who have NPM1 mutation and they are treated with venetoclax, these patients have an excellent outcomes with a CR rate exceeding 80% with MRD negativity more than 60%. So patient with NPM1 positivity has an excellent response to venetoclax treatment. So patient was started on azacitidine and venetoclax. His bone marrow examination was done at day 14, which we do routinely at our center. That those who are receiving HMA venetoclax, we do a marrow at day 14, and we see if the marrow is aplastic. If the marrow is aplastic, we do not give more venetoclax because it results in excessive myelosuppression and neutropenias. So the marrow was cleared of blast. When was withheld? Patient was MRD negative CR at day 30, post cycle 1. And currently patient is MRD negative at 1 year, currently on off-label venetoclax maintenance, which we are using in our patients like this. These are few of the drugs which were approved as targeted agents based on genomic profiling and genetic testing. And these include IDH inhibitors, FLT3 inhibitors, liposomal dono and cytarabine, BCL2 inhibitors, hedgehog inhibitors like Desdet, gilteritinib, CPX 351, and olutasidenib. Apart from 2 to 3 drugs like olutasidenib and ivosidenib, most of the drugs are available either in Pakistan, either they are imported or they are available through neighboring countries. The toxic spectrum of these drugs is very tolerable drug. There are no major side effects, neutropenic fever, differentiation syndrome in case of IDH inhibitors, Otherwise, these are tolerable drugs without any off-label much toxicity. So the conclusion would be that multiple targeted therapies for patients with AML and FLT3 or IDH patients are now approved in newly diagnosed and relapsed settings. These therapies have unique treatment-related adverse effects, particularly differentiation syndrome with IDH inhibitors, that must be carefully monitored and quickly addressed. So apart from ATRA, which is being known to cause differentiation syndrome, IDH inhibitors and few of the FLT3 inhibitors like gilteritinib are another drugs on horizon which leads to differentiation syndrome. As we further elucidate mechanism of resistance to IDH and FLT3 inhibitors, there will be need for next generation inhibitors. And there is ongoing need for novel, less toxic therapies, especially in relapsed or refractory settings and for patients with TP53 mutations. So I like to share this news that inshallah we'll be starting an NGS Marriott gene panel at our center very soon. We have equipment in place. We have personals in who have got the training, and the procurement of the panel would be is in process and will be received shortly. And we are targeting, first of all, we are starting from Marriott gene panel because we expect that most of these patients will have positivity. It will be a panel which will be covering acute myeloid leukemia, MDS, CML, ABL kinase mutations, CMML, MPNs, JMML. So whole of the myeloid neoplasm spectrum would be covered, and it would be a 58 gene panel that will certainly help us in prognostication of patients, especially considering taking decisions of transplant and post-transplant monitoring of these patients with MRD, with evolving data on MRD by NGS. Thank you very much.
Bismillahirrahmanirrahim. I will be briefly talking about NGS and applications of next generation sequencing in clinical oncology. So basically, next generation sequencing is that kind of technology which determines the RNA and DNA sequence to study the genetic variation between the disease-associated diseases and biological abnormalities. And NGS basically provides digital data, and each read is analyzed independently and it is quantitative. It also provides massively parallel sequencing, and it also provides overlapping reads which are aligned together, which are resulting in quantitative and high confidence variant calling. So let me tell you here the basic difference between the traditional Sanger sequencing and the next generation sequencing. In the traditional Sanger sequencing, we have only a single DNA sequence can be done, whereas in NGS, we have massive amounts of huge data which we can obtain, and we can analyze the genetic variants of the disease, and we can see how far the analysis can be done. The deep sequencing can be done with the help of NGS or the next generation sequencing. So it also has enhanced discovery of genetic variation, in where NGS provides a broader understanding of the genetics, and it has qualitative information in which mutations or changes from a standard reference can be analyzed in the form of single nucleotide polymorphism, the insertions and deletions, the duplications, inversions, and also cancer with heritable disorders. It also analyzes the pairwise differences, and where the disease resistance can be analyzed, the genetic risk factors or the morphological differences can be analyzed with the help of next generation sequencing. So understanding the genetic drivers of disease, specifically next generation sequencing, is highly sensitive method to quantify the genetic effects. It helps in the quantitative information, the copy number variation where reproductive health is involved, genetic engineering procedures, the gene expression where host pathogen interactions, especially between the bacteriological and virological diseases, the drug response interactions, the gene regulations, the small RNA sequencing, the antisense expressions, the protein DNA interactions where we have the DNA binding sites, the regulatory pathways, and for epigenetics where DNA methylation and the DNA repair is involved. So next generation sequencing again helps a lot in this part, and metagenomics where microbial community profiling is involved. If we see NGS in oncology and human genetics, it has the ability for empowering a deeper and more comprehensive understanding of the genetic drivers of the disease. And when we compare NGS as compared to the traditional methods of sequencing, in the traditional methods of sequencing, we had to know the prior knowledge of the variants, which are required for the qPCR assays. And as far as NGS is concerned, we have a hypothesis-free mutation discovery. And in the traditional method of sequencing, again, you can see the standard sequencing method. We had limited number of targets with qPCR. In NGS, we have a broader mutation coverage with expanded gene panels for enhanced mutation detection. The Sanger sequencing actually lacks the sensitivity to detect very low levels of DNA mutations, which are about 20%. With the help of next generation sequencing, this method becomes highly sensitive, and it provides information about low level somatic variants, which leads to 3 to 5%. It has multiplex samples with expanded panel size, gene targets to speed discovery, and it supports higher throughput research and discovery. So we are committed to making the precision medicine in oncology, which is a reality. We are doing it by combining the groundbreaking science and technology with the world-leading network of strategic partners. So this is the basic, you can say, the logo and slogan of Illumina combined with NGS. If you see, I would like to show you here a case study which was published in a gastroenterology journal. So in this, the cancer patient's typical journey today, what it is the standard screening. It undergoes recommended colorectal cancer screening, and the colonoscopy is revealed with a mass biopsy found in the adenocarcinoma. Then you see the clinical stages, which has left segmental, and it has scanned for metastatic disease, which is negative. And the pathology again reveals lymph nodes, which is positive for nodal metastasis. It has to go additional levels of molecular testing, which are performed, and then it is treated with adjuvant chemotherapy. By this time, the cancer almost progresses to the stage 3 or the stage 4 cancer, which becomes very problematic for the patient as well. So with the help of NGS, our vision, which is genomic testing, can improve the cancer therapy or the patient journey. It helps in earlier diagnosis of the cancer. Then when we perform the histology, the colonoscopy, it revealed the mass, which was diagnosed in stage 1 colorectal cancer. And ultimately, when it comes to the tailored NGS, it leverages the prior knowledge, which can be used for bioinformatics to assess the variants present in the patient's tumor. With the help of this, advanced disease is analyzed in the comprehensive ctDNA assay. And during the treatment, the patient can require additional medication, which can be informed by the pharmacogenetic profile. The envision that genomics-enabled medicine can improve outcomes can be helped with the help of next-generation sequencing, where diagnosis more at an advanced stage. The patients are diagnosed very early. There is an earlier detection, followed by comprehensive assessment and sensitive monitoring, which is again followed by novel treatment. So in Illumina, we have the two-site oncology 500 genome profile panel, where the comprehensive genomic profiling is available, including all the main variant types, in which we have genomic signatures which can identify the microsatellites. They can identify the tumor mutation burden. The fusion splice variants can be analyzed with the help of this technology, the two-site oncology panel of next generation sequencing. The CNVs can be analyzed, the copy number variants, the insertion deletions, and the SNVs. The genomics of the oncology breakthroughs, especially related with the TrueSight, I would like to discuss briefly over here. It assesses the hereditary risk panel, where it identifies the predisposing cancer mutations from single nucleotide polymorphism SNPs to indels to copy number variations in a single assay, which includes polygenic risk scoring. And if you look at the somatic variant detection, it again enables in comprehensive genomic profiling, in which it identifies the tumor mutation burden and the microsatellites in a single pan-cancer assay that covers relevant biomarkers and guidelines in the clinical trials. When we look at the myeloid disorders, again, it helps in the isolation. I'll discuss about the myeloid panel in the coming slides. And it also helps in fusion detection across the key biomarkers, which is the TrueSight RNA fusion and the true RNA pan-cancer. For the tumor classification, even for the methylation based, we have, which classifies the tissue of origin across the CNS tumors for the central nervous system. These are different myeloid panel analysis, in which we have the MI-SIG We have the mini-seq, which can perform again a broader range of pooled samples. Then we have the next-seq, which can perform about 70 samples pooled. And then we have the high-seq, which exceeds about 70 samples, which are more than 80 samples, or sometimes even 80 samples. So one of the basic, you can say, one of more commonly used for AML or for blood cancers, the upcoming next generation sequencing. We have the two-site HLA sequencing panel, because in HLA typing previously, there are chances where, because of the highly polymorphic region of the HL region in the human genome, we have a highly polymorphic region which gives to ambiguous results. So with the help of the HLA sequencing panel, unambiguous results are generated, and one can perform a comprehensive assay. In one assay, it provides high resolution sequencing of 11 HLA loci, replacing multiple assays. And these unambiguous results result in deeper sequencing with long inserts and paired reads, and enables phasing of all the exons and introns in the region for a more accurate high-resolution HLA typing. So this generates a sample to report solution complete workflow, which includes library preparation, sequencing data analysis, and reporting the data.